Just a quick heads up before we begin. Everything in this episode was accurate when we recorded it, but things move fast in evidence-based medicine. For the most up-to-date and definitive information, then please refer to Red Whale Knowledge. And if you notice anything that might need updating or have any feedback, then we'd love to hear from you. Now, let's get started.
Hello, I'm Fiona Ritchie.
And I'm Nik Kendrew.
We're both part of the Red Whale team.
Come with us as we make your life easier and reignite your passion for primary care.
Welcome to the Let's All Head to Stonehenge because it's the spring equinox primary care pod from Red Whale.
The primary care pod from Red Whale.
So grab your preferred drink of choice, your trainers or your dog lead, and here's what's bubbling up as we dive in search of our pearls for this month. Bubbling up this time.
Precocious puberty. It's not something we think about every day, so it can be hard to remember what's normal, what isn't normal, and what's a red flag. Join us as we talk you through our gems, our guidance and evidence made simple, on this topic, so you know exactly what to do, or at least where to look it up, next time you see this presentation on your triage list.
In support of Rare Disease Day on the 28th of February, we shared a pearl on bullous pemphigoid, a rare autoimmune blistering skin disease. But it's on the rise because it's a disease of old age with a mean age of onset of 80 years. Do you know how to spot it or how to manage it? Stay tuned as we break this down so that you'll know exactly what to do. And bubbling under for next time, obesity and weight management in pregnancy. Excess or insufficient weight gain in pregnancy can present a risk for mother and baby. Those early pregnancy weeks can feel overwhelming, especially when discussing a sensitive topic like weight. We're covering our updated article, Obesity and Weight Management in Pregnancy, based on the 2025 NICE guidance. Stay with us to find out why weight matters, how to talk about it sensitively, how to give simple, evidence-informed nutrition and activity recommendations, and when to screen for gestational diabetes and when to refer. We also have the sizzling topic of how to manage GLP-1 medications in the preconception period.
Perianal masses are a common presentation in primary care, but the causes can range from minor things like hemorrhoids to much more serious things like perianal cancers. Given that we are now consulting in many remote ways, this is an area where we need to be clear on our approach, ensuring that we don't miss something serious. We've drawn together the available guidance and want to alert you to some management steps that might just change your practice. So let's start with precocious puberty. So Nik, is it just me, or do you sometimes find yourself second-guessing what you've told a patient after they leave the room and wondering if it was actually right?
I'm glad you said that because it's not just you, Fee. That is literally me all the time. I can find myself doubting myself more if I'm more stressed than usual as well. And that's why I often have Red Whale Knowledge open on my desktop. And I try to use it to prevent myself having this doubt after the patient's gone. And I find that a quick look at Red Whale Knowledge whilst my patient is getting ready to be examined, whilst they're behind the curtains, is a bit of a lifesaver. I often say to them, I'm just checking your notes, having a quick look. And there I am just checking.
Yeah, like I often say, I'm just checking like the most up-to-date guidance, which I think, is a strength actually, isn't it? But the reason I ask is because this scenario happened to one of our Red Whale colleagues a few weeks ago, and they recounted this story to me. So they saw a 9-year-old girl with a flare of her asthma, and her mum mentioned as they were just leaving, she's got breast buds. And is that normal, doc? And our colleague went, yeah, that's definitely normal at 9 years old. And then as the door closed behind them, our colleague found themselves wondering, oh my gosh, actually, is that definitely right? But thankfully, they could really quickly check it because they knew that on Red Whale Knowledge, there is a GEMS exactly on precocious puberty, which is what we're discussing today. So they looked it up. What a relief. They were right. No awkward phone call asking the mum and the patient to come back if needed. We know you know what we mean.
Yes. And precocious puberty, it's a tricky one, isn't it? It's a topic that I'm really glad that we have this GEMS on. I love our GEMS because they're so succinct, they're easy to follow, and it's literally what you need in the middle of a consultation because you can really just find the information that you need. Now, because we don't see precocious puberty every day, we're unlikely to have the details about what's normal and what's a red flag at our fingertips. So this is a real lifesaver.
Yeah, exactly. So I thought we could have a look at this GEMS, which is based on the 2020 BMJ article on this topic. And then hopefully the next time this turns up, we'll all be much better equipped. So should we start with when to consider precocious puberty?
Yes, so we should consider precocious puberty in girls under 8 who have onset of breast development and increased growth velocity. Of course, we need to know what their height has been to be able to see that velocity, and we may need parents or caregivers to provide this to us. In boys, it's those under 9 who have genital development. Precocious puberty is rarer in boys, but importantly, more likely to have a serious underlying cause. So who should we refer, Fee?
Yeah, so this is a clear message. We should refer all children in whom we suspect precocious puberty, and some will need an urgent referral. Our history taking and examination will need to identify red flags, which will help us know if urgent referrals are needed, and will also help our secondary care colleagues to triage. So let's go through who needs an urgent referral. So firstly, all boys, because the cause is more likely to be pathological. So that's easy to remember. And then girls need an urgent referral if they have any of clitoromegaly, or the onset of periods before 8 years of age, or a combination of progressive breast enlargement over 4 to 6 months and progressive crossing of growth centiles. And then red flag features for girls and boys are pubic hair in infancy, and then thinking more systemically for girls and boys, a steep increase in growth, which we would spot by plotting height and weight and seeing 1 or more centiles being crossed within 3 to 6 months. A headache, visual disturbance, signs of raised intracranial pressure, because that might represent intracranial pathology. Polyuria or polydipsia, because that points to a pituitary or hypothalamic cause. A history that might point to a central nervous system problem, such as CNS trauma, meningitis, cranial irradiation, for example. Or evidence of McCune-Albright syndrome. And as a reminder, that's a rare genetic mosaic disorder where we might see café au lait macules, facial asymmetry, or signs of hyperthyroidism or Cushing syndrome. See more details on that in the GEMS.
And it's worth saying that if we see a boy with any of the features we just mentioned, then even though being a boy gets an automatic urgent referral, it would be a good idea to highlight those red flags in the referral to help paediatricians triage this as extra urgent.
Yes, and we should still examine boys thoroughly, even though we know we're referring them urgently, because there are features we could find, such as papilledema or a testicular lump, which would need different action.
So remind me what examination we should be doing in this scenario, Fee.
Yeah, so as well as a thorough history of what signs of puberty have appeared and when, as we've already alluded to, all children need neurological examination, genital examination, and plotting of their growth on centile charts. Nick, what can you tell us about investigations?
Yes, well, the guidance says that we may consider the following bloods in primary care for both boys and girls, and they would be LH, FSH, estradiol, and testosterone. But where I work, I'd have to refer those children in anyway. So if it's an urgent referral, I'd hand that over to the paediatric team. And if it was a routine referral, then I'd discuss how we enable that with the parents or the caregivers.
Yeah, I agree. So that's nice and clear. But I'm still a bit stuck on what to do about working out if there's been a change in height, because we rarely have recent heights for children documented, especially when they're getting a bit older. So is there something that can help us here?
Yes, well, I know what you mean with that. Now, they might not even be carrying their red books anymore, but this is helpful, and you can find it on page 2 of the GEMS. The RCPCH Childhood and Puberty Close Monitoring Growth Charts, for which there is a link in the GEMS, and we'll put it in the show notes as well, have puberty lines that show the normal age limits for the phases of puberty. If we don't have previous height centiles, then we could compare this to the mid-parental centile. Because if a child whose height centile was similar to the mid-parental centile, but then they had rapid growth, then a pathological cause is more likely in this scenario. There's a specific box with instructions of how to do this on the chart.
Okay, great. Yeah, so that's a nice little take action point there, maybe to go away and have a look at those charts, just so that you're familiar in case you need to use them. So moving on to management now, we've said that all need to be referred, some urgently. So what will our paediatric colleagues do? Well, this depends on the cause. If there is no serious cause, then a watch and wait approach may be used to assess the speed of changes. Causes can be put into two groups. Those that are independent of gonadotrophin, for example, a tumour or congenital adrenal hyperplasia, where sex steroid is produced independently of gonadotrophin-releasing hormone. These causes will be dealt with directly. Then there's those which are a result of early commencement of pulsatile secretion of gonadotrophin-releasing hormone, also known as gonadotrophin-dependent precocious puberty. Idiopathic precocious puberty is the commonest cause of gonadotrophin-dependent precocious puberty and is more commonly seen in girls than boys. For these girls, some will have no treatment, often if they are older than 6 years. For some, GnRH analogues may be considered if they are 6 years and under and adult high potential needs to be preserved, or if menarche needs to be postponed.
As we've said, this will be managed by secondary care, but are there things that we need to be aware of in primary care?
Yes, and I can see that many parents may ask us questions around care or future development, especially if their child had precocious puberty but did not have GnRH analogues, and it would be good for us to be informed.
Exactly. So there are 4 points in the GEMS at the end, which I think are helpful for us to know. Firstly, height. Children who have precocious puberty who do not receive GnRH analogues reach a similar height to those who are treated. Periods. The mean time to menarche after the start of puberty is 4.5 years in those with precocious puberty who don't receive GnRH analogues. There is an increased lifetime risk of breast cancer following earlier menarche, and that comes from epidemiological data. And there may be an association with metabolic syndrome and PCOS. So, here are our take-home messages for precocious puberty. Consider precocious puberty in girls under 8 who have onset of breast development and increased growth velocity. In boys, it's those under 9 who have genital development.
We should refer all children in whom we suspect precocious puberty, and some will need an urgent referral.
The GEMS and RCPCH growth charts can help us to identify red flags to help with this. Are you a GP trainee or do you know one? We've got some exciting news.
We know that GP trainee years can feel daunting and expensive, so Redwell has joined forces with the MDU to provide a free education package tailored to GP trainees, which has been really popular. Nick, can you tell us about it?
Of course, this is the GP Trainee Essential Support Package, exclusively available to GP-ST MDU members and affiliates. It's worth £165 and is designed to build your knowledge and confidence to help you pass your exams. So what does it include, Fee?
You get access to the whole of Redwell knowledge. That's over 900 written resources to support you during consultations and with exam preparation. Some of you describe it as like having an educational supervisor in your pocket. There's also a digital Top AKT Topics handbook, which contains topics that the RCGP says people find challenging in exams.
You also get access to 4 on-demand exam preparation webinars that demystify workplace-based assessment, AKT, SCA, as well as statistics and data interpretation.
And from August 2025, we'll be sharing a monthly video bite on common primary care presentations to support your learning even more.
So, who's eligible and how do they access it?
This all depends on where you are training. If you're a GP trainee in England, indemnity is provided through your deanery. But in addition to this, you can sign up for free MDU affiliate membership anytime during your training. You will then be able to access the GP Trainee Essential Support Package for free. And if you're a GP trainee in Scotland, Northern Ireland or Wales, you choose and pay for your own indemnity. Therefore, if you choose the MDU as your indemnity provider, then you will gain free access to the GP Trainee Essential Support Package. Just visit themdu.com to find out more. Click Choose to Join MDU and you can see all the options.
Once you're signed up, you'll receive a code from the MDU so that you can access GP Trainee Essentials as a free member benefit. And when you CCT, if you choose to continue with MDU Indemnity, then you'll get a free Red Whale course of your choice or a discount on Red Whale Unlimited to support you in your first year of practice. So, if this is of interest to you, then see the link in the show notes for full information and T's and C's, or search Red Whale GP Trainee Essentials to learn more. And now Fee has the Red Whale calendar.
So we've got on Friday the 27th of March, Kate and Catherine are in the studio to launch our new season of content with our Red Whale Live GP Update course. And then on Friday the 17th of April, David Plume is hosting a Red Whale Live cancer course if you need an update on that. On Thursday, the 23rd of April, you can choose between digital or face-to-face, with Io hosting a Red Whale Live from the studio, while Susan and Hussein are hosting GP Update face-to-face in London, which they'll then do again on Friday, the 24th of April. So 2 days to catch them if you'd like. Catherine is back in the studio on Wednesday the 6th of May for another GP Update live. And then on Thursday the 14th of May, Lucy Cox is hosting a women's health course. And finally, looking right ahead to June, Io is back in the studio on Thursday the 11th of June for a Red Whale Live on men's health. Do say hello to the presenters and give them your shout-outs or best intention stories. We love to hear from you. Management depends on the cause of precocious puberty, and GnRH analogues may be considered by paediatrics to prevent complications.
And that's the first pearl done. And if you had a chance to have a look at the written gems and you found that helpful, then you might like to know that there are 69 of them on Red Whale Knowledge, from hyponatremia through hearing loss, chronic pain, and also CKD. So take a look at those. So, Fee, how are you doing?
I'm very well, thanks, Nick. How are you doing?
I'm all right, thank you. I'm enjoying the sunshine today, which is a nice change.
Yeah, no, it's really lovely. I'm joining you from home today, but last week I was in the studio and I wanted to do a couple of shout outs. So we had a study day live for Bury St Edmunds, Colchester and Ipswich VTS groups. So stay tuned because I've got a couple of shout outs for those later. But yeah, it was a really lovely course and lots of interactions. So that was nice. What have you been up to, Nick?
Well, I've been managing my disappointment recently. So
I wasn't expecting that.
Had a date night. I need to sort of I need to recover from this. So went to the cinema last week, okay? And it doesn't matter what film it was. It was just, we were going out. Hadn't been to the cinema for at least a year. And it was one of those posh cinemas where you can like press a button and they come and bring a coffee to your chair.
I love those.
So we went a bit large and we thought, just treat yourself. You haven't been doing this for ages. So you had a nice coffee, even had a gourmet hot dog. I never had that before in my life.
Ooh, like
very
with crunchy onions and stuff.
Yeah, exactly. Lovely, brilliant. Enjoying all of that. Lights go down, ready for the film to start. Lights go up. No film. They couldn't get the film to play. Yeah, exactly. I mean, the disappointment.
Gosh.
God, it's
what
so
is it, like the 1920s?
Exactly. But you've got all these snacks and then normally you're in the dark and nobody can see them. And then there we are. You're having to sneak out and
That's so funny.
Yes. So I have to go and see a film in the future. That's a great story. Yeah, thank you very much. So,
maybe just stick to renting it at home.
Well, precisely. So not winning at life. How about you?
Speaking of your gourmet hot dogs, I feel like I'm coming out of hibernation because I actually tried a new recipe the other day.
Mm-hmm.
Which was
that recipe?
It was like leeks and cheese and pine nuts and like a pastry sort of case thing. So it was quite decadent. I don't mind saying probably cost more than I wanted to spend and more time as well. But there is a supermarket that does free recipe cards. So it was one of those.
Is this one of the ones at the higher end of the market?
You may say so. But it was really nice. And what was even better was the leftovers. I am a big fan of weekday lunchtime leftovers, just to get you through. So
fabulous.
Yeah, really enjoyed that.
But just to give us an idea of which supermarket it might be, if you just tell us the actual name of the recipe, and I think we'll all work it out. So what was the recipe called?
I think it was literally a leek and taleggio galette.
So there we go.
You're right. I mean, what was quite funny is I've never bought taleggio cheese in my life.
I didn't even know what it was.
Sorry, it sounded extreme, like even more posh. So I was standing at the cheese counter, not at the cheese counter, just like the cheese section for ages. And then I thought, do I turn to someone and go, excuse me, could you tell me where the taleggio is? But no, it was good fun and very tasty. So yeah, but a shout out to anyone who feels brave enough / mad enough to try a new recipe and then really regrets it.
Well, it always takes me much longer than it says on the card, so it's not a time-saving device.
Yeah, well, and there are certain chefs that do slightly, they're quite economical with how long things take, don't they?
Yes.
Yes.
We won't say his name, will we? But anyway, so we
love him dearly.
We do love him dearly.
We should move on.
So let's move on to our next pearl of the week, and this is bullous pemphigoid, and it's the most common autoimmune blistering skin disease, and it has an incidence of 4 cases per 100,000 patients per year, which makes it a fairly rare event in primary care. But it is on the rise because it's a disease of old age, with a mean age of onset of 80 years. So have you ever seen it, Fee?
Yeah, I was trying to think back. I think maybe once during hospital rotations, and it was one of those dermatology conditions that always comes up in exams, doesn't it, or pictures of it. But it feels like a bit of a distant memory. So I am glad that we're refreshing our brains with this today. And as you said, Nick, it's rare, but it's serious. So let's consider how we would spot it and what we should do. This was the subject of a clinical update in the BMJ in 2017, which incorporates guidance from the British Association of Dermatology. So, Nick, can you kick off by telling us what causes bullous pemphigoid, please?
No, I can't.
Oh.
Sorry. Because etiology is poorly understood. Possible triggers include trauma, furosemide, non-steroidal anti-inflammatory drugs, and antibiotics. There is an association with neurological diseases, including dementia, cerebrovascular disease, and Parkinson's disease, with the neurological disease appearing first. This is not fully understood, though.
Okay, fair point. So let's think about how we can spot it in that case. So let's think about maybe a patient who might present with this. As you said, Nick, the peak age of onset is 80 years old. It's very rare below the age of 50. If you see a blistering skin condition in a younger patient, say between 40 and 60 years old, then this may be pemphigus vulgaris, which is rarer still, and the blisters tend to be flaccid.
In terms of appearance, it's pretty dramatic. DermNet has some great pictures which are linked in the article. Initially, people may experience intensely itchy lesions which may mimic eczema. Then tense blisters known as bullae appear on the limbs and trunk, and the underlying skin can be normal or inflamed. Lesions may be single or widespread. Blisters or erosions can also appear in the mouth or on the genitals, so do ask about those. It's usually itchy. So how should we diagnose it?
So if we suspect a case, we should refer urgently to dermatology. If the disease is widespread, we should discuss on the same day by phone. Dermatology colleagues may wish to admit or start oral steroids. They will make the diagnosis by taking a biopsy and using direct immunofluorescence.
Okay, so that's quite clear. That's secondary care territory, but we need to arrange that urgent referral, and it will be same day for some. Let's think about management and prognosis now, and this is where we'll be adding value as well in primary care. Bullous pemphigoid is a self-limiting condition, but may last months to years. Whilst it's active, it's really unpleasant for affected individuals, and it contributes significantly to morbidity and even mortality in some cases. Remember, right at the top, I said that some drugs can trigger pemphigoid, things like non-steroidal anti-inflammatories, furosemide, and antibiotics. So if a drug trigger is suspected, we should stop the offending drug, as this may reduce the risk of relapse. Choice of treatment depends on the severity of the disease and fragility of the patient. These will be initiated in secondary care. Treatment success is defined as no new lesions forming and old lesions starting to heal, and this usually starts to occur after 2 weeks of treatment. The mainstay of treatment is corticosteroids, either topical, usually ultra-potent, or systemic. Topical steroids are the safest treatment and offer the best balance of disease control and safety, but there are obvious practical issues for frail elderly patients applying ultra-potent steroids all over their body on a daily basis. If systemic steroids are indicated, then prednisolone can be used. The British Association of Dermatology guidance emphasises the potential harms of systemic steroids. We should remember here about holistic care and consider whether a PPI and or bone protection is indicated. The initial starting doses for prednisolone can be found in the article. These will be started by secondary care and usually reduced after 2 to 4 weeks. It's noted, though, that there is an excess mortality in those who have systemic steroids.
Other options include immunosuppressants, for example, azathioprine, dapsone and methotrexate. These are second-line options if oral steroids fail or to enable doses to be reduced. And also, anti-inflammatory antibiotics can be used. Because of that excess mortality in those who have systemic steroids, there has been increased interest in other options. A recent, small, imperfect UK and German non-inferiority randomised controlled trial compared doxycycline with oral prednisolone, and this was published in The Lancet in 2017. All participants were also allowed to use topical steroids for symptom relief. Now, non-inferiority studies are odd. They let the researchers decide what constitutes a non-inferior response, in inverted commas. Prior to the study, they knew that doxycycline would be less good than prednisolone, and so providing it was no more than 37% less good, it would be deemed non-inferior. It was only 18% less good.
Okay.
Yeah, I know. It's a bit confusing, isn't it? But the authors concluded that oral doxycycline 200 milligrams daily offered acceptable blister control, with 74% of trial participants experiencing a significant improvement at 6 weeks. And serious adverse events were much more common in the steroid group.
Okay, so that's bullous pemphigoid, and here are our take-home messages. If you think a patient has it, refer to dermatology for biopsy and confirmation. Call them to discuss.
Ultra-potent topical steroids offer the best balance of disease control and safety, but can be difficult practically.
Oral steroids carry high risk of harms.
Oral doxycycline is an increasingly evidence-based option and may be used at the beginning alongside topical steroids.
And just before we go, Fee, you've got some shout-outs, haven't you?
Yes, I just wanted to say a quick hello to Maddie from Colchester and Andrea as well, who both told us that they love listening to the Redwell podcast, especially whilst doing their running and all sorts of other things. So thank you. So lovely to hear from you.
Yeah, we absolutely do. And if you stay listening, then we tell you how to contact us. But also remember that in the show description on your podcasting platform, there is a button where it says send a text, and you can also send us a text anytime about anything big or small, and we love to hear from you, as Fee said. Now, if you're hankering after a Redwell Knowledge subscription, then we're offering a 10% discount on Redwell Knowledge for our fabulous Redwell Pod members. How do you become a member of the pod, I hear you ask? Well, if you are listening to us, then you are part of our pod. And all you have to do is go to redwhale.co.uk, put Redwell Knowledge in your basket and enter the code RedwhalePod to get 10% off. And here's a small print. The discount is only for this product and it won't work on anything else. And please also note that this voucher code is all one word and all lowercase, and it can only be used once. Redwell Pod.
If you've enjoyed listening, then please give us a 5-star rating on whichever platform you use. It only takes a few moments and we'd really appreciate it. And if you can spare a little more time, then please leave us a nice review too. Because of the way the algorithms work, it means that other people just like you can discover us.
And of course, putting algorithms to the side, there is no greater recommendation than a word of mouth recommendation. So if you've got value from listening to the podcast today, then don't keep it a secret. Please tell everybody that you know who might also benefit from listening. All the resources that you need are in the show notes, and all the links are in the show description on your preferred podcasting platform.
You can also find us on social media. We're on Facebook, Instagram and LinkedIn. If you want us to see something about the podcast, then please use the hashtag RedwellPod.
The other thing that you can do if you click on the link in the bio is to leave us a voice message telling us about anything that you found helpful or would like us to go over.
You can also email us. Our address is podcast@red-whale.co.uk. And if you want to tell us about a change to your practice that has come about by listening to us, then please email us at impact@red-whale.co.uk. Until next time, I'm Fiona Ritchie.
And I'm Nik Kendrew.
Remember to keep Redwell knowledge open on your desktop at work, so we're with you when you need that bit of extra information or reassurance.
Take care and look after yourself. Bye-bye.
Goodbye.